What are the investigations needed in patients with PCOS? The first investigation is ultrasound, and the second investigation are the biochemical investigations. So what is the seen on ultrasound to diagnose PCOS? The two things we see, first is the number of eggs, number of antral follicle. Antral follicles are all the follicles which measure from 2 mm to 9 mm are the antral follicle that we need to measure to diagnose a case of polycystic ovarian syndrome. As per the recent criteria, previously there were 12 antral follicles if they were present in one ovary, but now because of high definition ultrasounds available, the criteria has been increased to 25. Okay, so there is a characteristic pattern of the placement of antral follicles in patients with PCOS because of the excessive stromal tissue which is responsible for increased production of androgens also. So that excessive stromal tissue will push the follicles in a peripheral fashion, as you can see here in these images. All the follicles, they are pushed in a peripheral fashion, like a ring-like fashion. So peripheral arrangement of the antral follicle is characteristic of polycystic ovarian morphology. Okay, so this, if more than 25, can diagnose polycystic ovarian morphology, picture of the ovary. Another thing which can also diagnose PCOM on ultrasound is the volume of the ovary. So any volume, even in single ovary, need not to be present in both the ovaries. Single ovary measuring more than 10 centimeter cube, it means that ovary is a polycystic ovarian morphology ovary. Okay, anything more than 10 centimeter cube is a big ovary. Coming on to biochemical investigations. First is serum testosterone levels. Serum testosterone level and 17-hydroxyprogesterone, they both are marker of hyperandrogenism. Serum testosterone level more than 150 nanogram per dl, they are suggestive of adrenal causes. Less than 150 nanogram per dl are more suggestive of polycystic ovarian syndrome. The usual level of testosterone, they are around 20 to 30 nanogram per dl. They don't exceed, in normal women, the testosterone levels don't exceed more than 20 to 30 nanogram per dl. But in patients with polycystic ovarian syndrome, usually the testosterone level rises up to 50 or 70. So anything more than 50 is considered increased testosterone. 17-hydroxyprogesterone, this is a marker of adrenal activity. So this is one of the ways to differentiate the patients with PCOS from congenital adrenal hyperplasia. Then is the fasting serum insulin. Because the patients with PCOS, they suffer from insulin resistance. So their serum insulin will be, the fasting serum insulin will be elevated. Usually it is more than 20 to 30 units per ml. If it comes more than 20 to 30 units per ml, then it is a sign of insulin resistance. Then is something known as fasting glucose to insulin ratio. This ratio, if it is less than 4.5, it means the insulin is not released in appropriate amounts to utilize that glucose. So that is a marker of insulin resistance. Fasting and 75 gram OGTT. I will be explaining this again. Then is quickie, that is quantitative insulin sensitivity check index. So there is a formula for that. Anything more than 0.33 is suggestive of insulin resistance. Then is HOMA-IR, the homeostasis model assessment ratio. So these all were the tests for insulin resistance. But the mainstay for diagnosis of insulin resistance, which is most commonly done, is OGTT. Not serum fasting insulin, not fasting glucose to insulin ratio. not quickie, not home IR. We are not using all these things in our daily clinical practice. What we are using is OGTT, that is oral glucose tolerance test. What we do in OGTT is we will be giving the patient with a glucose load. Okay, and after that, 2 hours of after that, we will be seeing how much the glucose has been metabolized by the body. Okay, so that is what the basis of OGTT is. We want to see how much resistant that patient is for insulin. That is why it is known as insulin resistance. Whether the glucose challenge which was given, whether the body can release insulin enough to metabolize that glucose which has been given. So that is the mainstay for diagnosis of insulin resistance, OGTT. The normal values are less than 140 milligram per DL, but if the 2-hour value it comes between 140 to 199, it means it is impaired glucose tolerance, and anything more than 200 is over diabetes mellitus. A word on dyslipidemia, because there is some syndrome known as metabolic X syndrome, which is seen in the patients with polycystic ovarian morphology, because mostly it is seen in patients which are obese PCOS rather than the lean PCOS. So lipid profile is something which, although we don't need it to diagnose PCOS, but it is something which we should do in a patient with PCOS, because in 70% of the women with PCOS have elevated lipid levels, and it is associated with metabolic abnormalities. Usually PCOS women are seen to have high triglyceride levels and lower HDL levels. Okay, so dyslipidemia is one of the associated tests which we should do in patients with the PCOS, apart from all the biochemical tests which include the androgen level measurement, the insulin resistance, and lastly the lipid profile. So thank you.